Hey everybody, this is Dr. Paul Singh from the Eye Centers of Racine and Kenosha out here in southeastern Wisconsin. I'm an anterior segment and glaucoma surgeon and a big fan of the MIGS space. I think, like a lot of you, it's been exciting to have such a proliferation of technology and the options to treat our patients much earlier in the disease state. And I think one of the hallmarks of MIGS is a high safety profile of these various procedures. But what it's also done for me is, I think, reestablish or actually change my paradigm and my thought process of what is considered a controlled glaucoma patient. Now, if a patient has pressures that are controlled, fields that look good, and nerves that are stable, that may be one element of control. But if they have poor compliance or quality of life is not quite as good, that is now part of my definition of uncontrolled glaucoma. And I think that is the balance of efficacy and really trying to control pressures, but also maintain a high quality of life. And so today I have a really good friend of mine, one of my iTrack colleagues, Dr. Mahmoud A from Dean McGee Eye Institute, who has done a number of studies and published papers on iTrack and other MIGS devices. And today he's going to talk to us about some of his studies that also deal with quality of life. Hi, Mahmoud.
Hey, well, how are you?
I am good. I'm so happy to have you hanging out with me today, man. What you been up to?
Hey, it's been great. I share your enthusiasm about the MIG space, and as you know, we're both two guys that treat glaucoma that are very excited about MIGS, and I'm happy to talk to you today a little bit more about a recent study that I've done at Dean McGee Eye Institute.
Yeah, I actually love to talk to you about that because I think you presented, it was a study on the efficacy outcomes. It was a large multi-physician retrospective study that tracked the efficacy outcomes of the iTrack in almost 869 patients, POAG patients, over a 36-month period. It's a lot of patients. But I think to me, when I looked at the study, what shocked me more than anything else was the fact that they were all performed at Dean McGee Eye Institute, but there were 2 attendings, 4 fellows, and 22 residents? That's incredible. Tell us about that.
So it's a bit of a unique study, and it shows you that we're at an academic center and we have residents and fellows here, and it really speaks to the reproducibility of iTrack canal-based surgery. And we included everything. Usually you kind of hide what the residents have done or the fellows have done, but here we saw some really good data that included residents as well as fellows and a couple of attendings. And, it just basically shows you that iTrack can be done even by residents, and we can get really good data that we've presented. Paul, the unfortunate thing is I think iTrack carries along with it some prehistorical notions that it's a procedure that is difficult to do. And I think it's because of canaloplasty, traditional canaloplasty. When traditional canaloplasty came out, it was an elegant procedure, very effective procedure, but technically challenging. And I think people in my talks with people in the United States and overseas, they think iTrack is traditional canaloplasty. And hopefully this study will show that it is not traditional canaloplasty. It's an ab interno approach. It's definitely in the MIGS space and can be done by residents with very good results.
Yeah, Mahmoud, I agree with you. I think for me, the iTrack system, from a learning curve perspective, was very short. I think that the skill set needed to adopt any new procedure is something that we always look at. And for surgeons, whether it's residents or even comprehensivists and those out in practice, the skill set is very similar to other MIGS procedures, whether it's a stent or even phaco. And so if you have the ability to maintain a good view with your gonio prism, and the hand motions are very similar to what I've used before. And what I love so much about it, I think more than anything else, was the verification of where you are. I think we're understanding anatomy better when we're with the iTrack catheter, going through the canal, seeing it, the red light going around for 360, and really you truly address and you truly, I think, admire the outflow system. I'm not sure what your thoughts on teaching residents. Was that something that they commented on as well?
No, it's a big deal. I think knowing where you're at all times is a big advantage. And we're talking about treating the canal-based system, and so you want to make sure you're in it. You want to make sure you're treating the right area. So I think having that built-in GPS system, if you will, is for sure reassuring to residents as well as attendings, because You can be coursing along in canal and all of a sudden go through a suprachoroidal space. And if you don't have a light to tell you where you're at, you won't know. Um, I agree with regards to the learning curve. I think the major part of the learning curve is really visibility, and that speaks to all the MIGS. And so I think all the MIGS have their little nuances of what you want to do and what you don't want to do. And iTrack certainly follows that rule too. And so, but very, very easily done procedure, as evidenced by our study here.
And not having a foreign body in the eye, just from a teaching perspective, is that a benefit? Not have to worry about leaving something not quite right in the eye,
Yeah.
from a stress level from a teaching attending.
So I think that's really big. I think the fact that we can enter the eye in a very minimally invasive way, treat the whole outflow system, and not leave behind a device or take away tissue is pretty huge. And patients, by the way, love it. It's all about quality of life right now. And one of the things that I'm frequently asked by patients is, what are you going to leave a device in my eye? And if so, when we do some MIGS that do leave devices in the eye, I'm sure you get the same thing from your patients. They'll ask you, well, what is it made of, and where's it going to go, and do I have to take it out later on, and can I go through TSA at the airport and check through and all that? I mean, you get a slurry of questions that are asked, but I think the ability to treat the outflow system in a very natural way, so to speak, without leaving anything behind or destructing tissue is a big point here.
And of course, for me, I think it's wonderful is being able to tell a patient, and at the end of the day, glaucoma is a progressive disease. And if I need to do more, this is not inhibiting me from doing more procedures or a different procedure later on within the angle, or of course the subcon surgery if I need to later on. So having that options and keeping those options open, I think is really also a nice benefit. But before we go in further, I want to ask you about, go back to the study.
Yeah, absolutely. So one part of the study is that, like I said, we looked at iTrack alone group, and so their mean intraocular pressure was 21.2 prior to surgery, and following them all the way out to 24 months, we noted probably just under a 27% reduction in their intraocular pressure. And one thing that I want to point out here is that, when you start following these patients out for quite some time, you get attrition of patients, right? This is a non-prospective study. It's a randomized study. And now that these procedures are so efficacious and their safety profile is so high, they go right back to their referral sources. Dean McGee is a major referral source. And so once the patients had their iTrack procedure, they would go back to their referral sources if they did well. Another interesting part of this study, Paul, is that we actually stratified the data too to look at patients that had a mean IOP that was 25 or higher. A lot of times I've talked to a lot of people and they say, yeah, well, with the iTrack, you can't really treat patients that have higher intraocular pressures. And so we actually stratified the data and looked at patients that started off with a mean IOP of greater than 25. And in those patients, 2 years out, they had a drop of about 40% in their intraocular pressure, and about a 46% reduction in their medication burden. So that's 2 years out for the iTrack alone. And so these patients went from a mean medication utilization of 2.2 down to 1.2 at 2 years out, which is pretty impactful. And when we talk about quality of life, again, this affects the patient. We also looked at obviously the iTrack phaco group now. And so we also stratified that data too. And we looked at patients that started off with higher than 25 pressure. And so we actually looked at a subset of the data. And these were patients that started off with a pre-op IOP median of 30.7, and they dropped down to 19.1 at 2 years. Again, about a 40% reduction in their intraocular pressure and about a 40% reduction in their medication burden too at 2 years. So they went down from 1.6 to 1 medication. So I think the study does show that not only is this procedure efficacious with regards to lowering intraocular pressure, really across all stratas of intraocular pressure, pre-op, mean IOP, but also it's very effective in lowering the medication burden.
But that's a great point, Mahmoud. You know, the balance of efficacy as well as the compliance issue and medication burden reduction, that's really important as we define rather, what is efficacious or not. But in terms for me, I look at it also as there's different goals that we have when we approach a MIGS procedure. You know, sometimes our goal is, I don't care if you're on medication, just get the pressure down. Or there's some people where the pressures are controlled, but they're on 3 or 4 medications. My goal is just to get them off some meds, keep their pressure stable. And it sounds like, for what you're telling me, that the iTrack in your hands at least has the ability to do both. And depending on how high the pressure are, it can bring the pressure lower. Or if the pressures are low to begin with, it can at least stabilize the pressure and get them off of some meds. Has that been your experience as well?
Yeah, absolutely, absolutely, and in real clinical world, you know, the data kind of speaks to that also, in that the iTrack phaco group had a mean IOP that was lower than the iTrack alone group, and so we did surgery on those iTrack phaco groups, even though their mean IOP was low to begin with, basically to get them off medication. So yeah, it's kind of we're kind of tailoring the procedure to give us what we want. In other words, sometimes patients need a lower medication burden, and you're not really worried about their IOP. And sometimes patients that, like we stratified in the higher than 25 category, really needed to get their pressure down, which we're able to show that. So yeah, I absolutely agree. I mean, but it's nice to have a procedure that can kind of tend to both of those quality of life measures. And hopefully we'll be able to talk about the safety profile, which is the biggest thing about MIGS too.
Actually, that's next. I was actually going to ask that question. I would love to hear, you know, we always talk about safety being a big part of MIGS procedures. And tell us, in your study, what was your safety profile, adverse event profile like?
Yeah, so one of the biggest impactful things that we've learned from this study is really the safety efficacy, or the safety profile of iTrack. In that we looked at adverse events, and one of the major adverse events that we classified as an adverse event, because I often asked about this, is a post-operative IOP spike within 1 week of surgery. A lot of physicians are concerned about a high spike after surgery. And we noted that in the study, about 8 to 10% of folks had an IOP of greater or equal to 30 at 1 week. Now, that might seem a little bit high, or it might seem a little concerning, but when you think about a good portion of our study had severe patients that had pressures that were higher than 30, higher than 25, like the group that we looked at that was higher than 25, their mean IOP was 30. Essentially, they regressed back to their baseline pressures, because we don't start drops after the procedure. But nonetheless, we classified it as an adverse event, and more, you know, just to look at that a little bit further in detail to understand what that means, only 0.3%, Paul, of those patients that had a spike in pressure from the iTrack phaco group required further intervention to treat that IOP spike. So in other words, that IOP spike was transient. We probably treated it with medication, but it did not require us going into surgery. And when we talk about quality of life and not pushing a patient into more invasive surgery, I think that's very impactful.
Absolutely, no doubt about it. And I think for me personally, I think that you can also decide to stay on medications if you want to. Some doctors say if someone's more moderate or severe, they'll keep them on some of their anti-glaucoma medications initially and then take them off, you know, after a week or two as well, depending on it. But I personally feel like if you have a pressure spike going into it, it has not been something that I've had to transfer into a secondary procedure or a TAP or anything else as well. So I agree with you. In our experience, it's been the same. And I think because of the high patient satisfaction, high quality of life, as well as low adverse event issues, it has really changed my decision-making processes.
Oh, so absolutely. I think you alluded to this when we first started talking about this, and that is, you mentioned maximal medical therapy. My definition of maximal medical therapy has radically changed, and it seems like it's getting less stringent as the years go along with these safe procedures that are pretty efficacious. So back in the day, maybe 10 years ago, after finishing training or whatnot, we were taught maybe 3 or 4 drops. My maximal medical therapy right nowadays is maybe 1 or 2 drops at most. You mentioned the patients that have difficulty remembering the drops, intolerance, or a cost issue or whatnot. Those are a majority of our patients, Paul. And so, absolutely, when you have a surgery that has a safety profile like the iTrack does, as well as efficacy profile with reducing the medication as well as intraocular pressure, you better believe I go to it very early on. So after laser or a drop, especially if they're on a combined drop, there's no question about it. We're going to this because I tell my patients, hey, the safety profile is so good that there's not much risk here. We of all those cases, Paul, we did not have one case of infection.
And so I think we're seeing more and more data out there confirming that compliance is an issue, and non-adherence can be a risk factor for progression, whether it's fluctuating IOPs or not as well. So I think it's great points you made. Thank you for that.
Another thing that I didn't mention earlier on, Paul, is that we actually, when we looked at the data, we noted that only 6 to 14%, depending on whether it was in the iTrack alone versus iTrack phaco group, required further invasive glaucoma surgery period over the 3 years. So I don't know about you, but if I can tell my patient, if I can keep you from having a trab or a tube for 1 year, it's beneficial. The other part of the study that I thought was also impactful was the fact that, we can use the iTrack to deal with patients that have seriously high intraocular pressures. That when we stratified the data, early on when I started doing iTrack, a lot of folks said, well, it sounds like a very good procedure, dilating the outflow system, rejuvenating it, restoring it, sounds great. But you know what? I have patients that sometimes have a really high pressure and they're on all medications and Diamox. And so I'm sure this procedure is not powerful enough to bring that pressure down.
Thank you so much for giving us some of your overview of your study. I've looked to you as a mentor for the iTrack for many years, and your data speaks for itself. And to me, what I've taken away from this data and other data sets you've published already is the confidence to go in as a standalone procedure. Many of our surgeons do feel comfortable performing MIGS with a cataract. You're already going in the eye, patients are going to be happy having improved vision, so there's really the bar is a little lower. But to go in as a standalone MIGS procedure, you really want to deliver. And not only IOP reduction, but also medication burden reduction. I think that's an area of growth for us as a profession and as a MIGS space, as a standalone MIGS. And with your data, your experience, and even in my experience so far, is that the iTrack does deliver, maintaining a high safety profile, yet also significant IOP reduction, also not limiting you from future surgical options as well. So your data is great. And I just want to say thank you so much for taking the time to spend with me and educate me again and the rest of our colleagues out there. Appreciate all the work you do, buddy.
Always a pleasure, Paul. Thank you very much. And I love any opportunity to chat with you because I learned just as much from you also. Thank you.